Welcome to the Encephalitis Podcast. My name is Prav, and I'm from Encephalitis International. Today, we'll be talking about the development of global training modules for doctors in low-resource settings. To learn more, I'm grateful to be speaking to Dr. Aline Matos. Dr. Aline MB Matos is a neurologist and neuroimmunologist based in Sao Paulo, Brazil. She's a faculty member at Centro Universitario São Camilo and clinical researcher at the University of Sao Paulo, and has been following patients with encephalitis and neuroinflammatory syndrome since 2015. In 2019, she was awarded the International Seed Funding Grant by Encephalitis International to investigate clinical and laboratory features of encephalitis during arboviral epidemics in Brazil. She currently serves as secretary of the Neuroepidemiology Scientific Department at the Brazilian Academy of Neurology. Finally, and relevant to this podcast, Dr. Matos was part of the Global Training Modules Working Group, which was set up by Encephalitis International and was actively involved with developing these modules. Dr. Matos, welcome to the Encephalitis Podcast. How are you doing?
Hi, Prav. Thank you for having me here today. It's a great pleasure to be talking to you today and be here with Encephalitis International in this initiative of having a training module. I'm very happy with it.
Absolutely. And yeah, so to start off, what gaps in encephalitis diagnosis and treatment do these modules aim to address, particularly in low and middle income countries?
Okay. I think, Prav, that the most important gap these modules address is actually very fundamental recognition. Um, Many clinicians, and I'm talking here even about very good clinicians, are not trained to think encephalitis early enough, as I see. So what the modules try to do is to translate complex specialist knowledge into something practical. How to recognize encephalitis at the bedside, how to approach it as a syndrome, how to prioritize investigations, and importantly, when to treat before you have all the answers, because that is the commonplace for encephalitis. You do not have all the answers in a time we wish we have, but this is what we have, and we have to be quickly.
Why is encephalitis still so often missed or misdiagnosed globally?
I think encephalitis is difficult because it doesn't present as a test where you have positive for encephalitis and negative for encephalitis. It presents as confusion, behavioral changes, psychiatric symptoms, seizures, and it's quite common that patients are initially labeled as having delirium, primary psychiatric condition, stroke, non-specific encephalopathy. Um, and also the second issue is that the diagnosis depends on tools such as lumbar puncture, antibody testing, which are not always available or not available in time. So we have a condition that is clinically heterogeneous and diagnostically dependent. That combinations makes it very easy to miss.
Yeah, thank you for saying that. Yeah, it's a multitude of factors. And so what are the consequences, both clinically and socially, of delayed or incorrect diagnosis?
Well, I would say that clinically, encephalitis is a neurological emergency. And if you delay treatment, especially in conditions like herpes simplex encephalitis, you are directly increasing mortality and long-term disability. And I'm talking here about memory impairment, personality change, epilepsy, and psychiatric symptoms. And this affects not only the patient, but the entire family in many settings, particularly in low resource environments. This can mean loss of income, long-term dependency, and significant social burden. So it's not just an acute disease, it's a life-changing condition.
Talking specifically about the clinicians, what are the biggest challenges that clinicians face in low resource settings when diagnosing encephalitis?
Well, I would say that the challenge fall into three main categories. First, access to diagnostics. CSF analysis, for instance, may not be readily available. PCR testing may be delayed or even absent. MRI may be inaccessible. The second thing is recognition and training. Sometimes the issue is not only the absence of tests, but uncertainty about when to suspect encephalitis, which patients need urgent treatment. Third, I would say system level barriers, delayed referral pathways, limited ICU availability, and I think something that is really a problem, particularly in my country, is the lack of rehabilitation services. So the clinicians often working with in a context where decisions must be made with incomplete information and under pressure.
I want to focus on that second point you made about when to suspect encephalitis. And my next question was, what are the key must not miss signs or symptoms that clinicians should look out for?
Well, Prav, if you had to simplify it as much as possible, I would say any patient with altered mental status lasting for more than 24 hours without a clear cause should trigger concern. And the key flags would be if you have the symptoms associated with fever, new seizures, focal neurological deficits, behavioral or psychiatric changes. And I would also emphasize these psychiatric symptoms can be neurological because it's quite common that people miss this particular point. And this is true, especially when we think about autoimmune encephalitis.
Brilliant. And now moving on to the modules themselves, what guidelines or evidence base underpin these modules?
On the infectious side, we rely heavily on the International Encephalitis Consortium definitions published in 2013, which give us a structured way to recognize and investigate encephalitis. On the autoimmune side, I would say that Francesca Garau's criteria are essential because they allow us to make a probable diagnosis early without waiting for the antibody confirmation, with a limitation in many settings, not only in low or middle income settings, but everywhere, I guess. And more recently, there is also increasing alignment with WHO guidance on CNS infections, particularly in terms of applicability in low resource settings.
Brilliant. My next question is, how do the modules support decision making when resources are constrained?
Well, this is actually one of the most important aspects. The modules are designed around a key principle. You do not need perfect information to act safely. They emphasize clinical pattern recognition, prioritization, and early empirical treatment. For example, you should not delay a sequelae in a suspected encephalitis just because you are waiting for image or lumbar puncture. And similarly, when autoimmune encephalitis is the case, you can often approach it syndromically, even without antibody panels.
Amazing. And could you talk about how the modules are suitable for different professional groups, such as doctors, nurses, and clinical officers?
Well, formally, they are designed for doctors, but in practice, I think they are highly relevant for a broader group, such as nurses, clinical officers, advanced practitioners, because encephalitis care is inherently multidisciplinary. So I think recognition often happens at bedside, and that is not limited to physicians.
So I think we've been talking about the clinical setting and the bedside. I want to talk more broadly now. How should organizations or ministries of health integrate these into training systems?
I think the key message here is these modules should not exist in isolation. They should be integrated into undergraduate training, residency programs, continuing education, and local clinical protocols. And ideally, they should be adapted to reflect what diagnostics are actually available, what treatments are accessible, and how referral system work locally. Because implementations is always contextual.
Brilliant. And I want to move on to more about yourself. And I was wondering what motivated you personally to develop these modules?
Well, encephalitis is kind of a passion research for myself. And is one of those conditions where timing changes everything, you know. And I have seen cases where an early diagnosis completely changed the trajectory, and others where delay leads to devastating outcomes. And I tell you this, especially remember two patients I saw this week. One is a student of physics, and the other one is a lady that just had her first grandson, and you know the sequelae is probably going to change their life forever. And there are losses of memories that have a massive impact on their lives. I think I'm also very motivated by the issue of equity. Access to timely diagnosis should not depend on geography. So this work is really about making specialized knowledge more accessible and more actionable. I think these are the main things.
Thank you for sharing that, Dr. Matos. And what's your message to clinicians working in resource limited settings?
I would say your clinical judgment is extremely powerful. Yeah. Even without all the tools, recognizing the syndrome early and acting on it can save lives. It really can. Do not wait for certainty in a situation where delay is harmful. And also, the difficulty of managing encephalitis in this setting is not a reflection of individual failure, because I hear that from many colleagues. It's also a systems challenge. Yeah, that's pretty much it.
Oh, that's really brilliant. Thank you. We are coming towards the end of the podcast, and my final formal question is, what gives you hope about improving encephalitis care globally?
I think what gives me hope is that we are moving in the right direction. At least it's what I can see in the last couple of years specifically. We now have better diagnostic frameworks, growing awareness of autoimmune encephalitis and infectious encephalitis, and the information that Encephalitis International brings has a lot to do with it. I think we have more global collaboration and initiatives like these modules are specifically trying to reach clinicians where they are, not just in highly specialized centers.
Amazing. So we've come to the end of the podcast, and I just was wondering, before closing, is there anything that we have not discussed that you'd like to mention?
Mm. If I could leave one final thought, it would be this. Encephalitis does not end when the acute phase ends. The long-term sequelae, cognitive, behavioral, social, are often invisible but deeply impactful. So improving encephalitis care is not only about saving lives, as we said earlier, it is about preserving lives. And I think we also have to have a special look into what happens after the acute phase.
Very important message to end on. Dr. Matos, thank you so much for sharing your time and expertise with us.
Thank you, Prav.
That was Dr. Aline Matos, neurologist and neuroimmunologist based in Sao Paulo, Brazil. And this podcast has been about the development of global training modules for doctors in low resource settings. If you're a doctor or clinician working in such a setting, please do complete this free training for which 2 CPD points will be awarded. Finally, I would like to thank you, the audience, for listening and watching. If you have been affected by any of the issues raised, wherever you live in the world, please contact our support services. Encephalitis International is here to help in whatever way we can to achieve our aim of ending death and disability from encephalitis. For all our information and support services, please visit encephalitis.info. And if you have found this podcast useful or interesting, please consider supporting our life-saving work by visiting encephalitis.info/donate. Thank you again, and see you next time on the Encephalitis Podcast.